said.
Yeah, exactly. All right, abstract 615, the association of vulvodynia and urologic urgency and frequency, findings from a community-based study by Dr. Harley.
Good afternoon, everyone. Thanks for having me talk about vulvodynia. Do I put these slides up?
Oh, they should be coming. There you go. Yeah.
Okay, thanks. We're going to take a bit of an interlude from IC and bladder pain syndrome and talk a little bit about vulvodynia. So vulvodynia is chronic pain in the vulva. It usually is diagnosed as a condition of exclusion once you've ruled out dermatologic and other gynecological conditions and left with this horrible, severe pain. It usually gets this diagnostic category. It can occur from the very first time that a woman tries to insert a tampon or has a pelvic exam, or she can have a period of pain-free intercourse and pelvic exams, and then all of a sudden something can happen and it develops. It can be provoked or unprovoked. It can come on gradually or acute. But what we've shown recently is that by age 40, about 8% of women in the general population will have experienced vulvar pain for 3 months or longer. In this study, we screened about 30,000 women in Minnesota between 18 and 40 years of age from one of the largest health HMO plans, women who were seen in over 40 clinics for reasons, anything under the sun, a broken finger, a routine exam, not specifically for gynecologic disorders, to mirror the general population. I then clinically confirmed 234 women who met the ISSVD criteria for vulvodynia and matched them to 234 controls, and then administered a questionnaire, which I'll talk about, on urological symptoms. But most importantly, in this analysis, we excluded women who either self-reported interstitial cystitis or painful bladder syndromes to really try to look at the relationship between vulvodynia and urinary symptoms. We used the pelvic pain and urgency frequency questionnaire, but only questions 1 and 2 because the rest of the instrument overlaps with symptoms of vulvodynia. So we really want to just get at frequency of daytime and nighttime urination, nighttime voiding bother, and urgency and bother after going to the bathroom. And so this is what we found. We found that in general, women with vulvodynia were more likely to report greater amounts of voiding during the day, and they also were more likely to report more nighttime voiding as well. But one of the strongest findings that we found was that relative to women who never voided at night, those who voided and reported at least usually or always having bother associated with it were 2 to 3 times more likely to be vulvodynia women. And when you restrict it to just those women who do get up at night, relative to those who get up and never have any bother, those who get up and have usually or always bothersome symptoms associated with it were 4 to 5 times, or about 4 times more likely to be women with vulvodynia. And one of the strongest associations we found was that relative to women who didn't have any urgency or bother after voiding at any time during the day, those who reported moderate to severe urgency after going to the bathroom were 18 times more likely to be women with vulvodynia. So the conceptual model that we've looked at with respect to trying to understand the etiology of vulvodynia is to look at a real biopsychosocial approach. We've shown that a lot of environmental exposures, such as reproductive, gynecological, and other things, are associated with vulvodynia, as well as psychiatric and psychological morbidity that we believe operates through an immunoinflammatory response mechanism that leads to vulvodynia. In this data, we suggest that vulvodynia is associated with lower urinary tract symptoms. We don't really know the exact temporal relationship with it, but what we do think is that the same kinds of etiological predictors that we see for vulvodynia may also be in play for other types of lower urinary tract symptoms independent of interstitial cystitis and bladder pain syndrome. And I'm blessed and privileged to be the co-PI of the Scientific Data Coordinating Center for the Prevention of Lower Urinary Tract Symptoms consortium that is really trying to understand exactly this, the kinds of factors that we can intervene on to really prevent the onset of lower urinary tract symptoms. And I think that some of what I've shown here will hopefully be implemented in that type of study as well, in the type of work we'll be doing in the PLUS consortium as well. And I think I stayed within my time limit. Thank you.
Thank you. We've got just a minute for questions. Good, thank you.
I'm Dr. Hana Yoon from South Korea. I would like to ask you about the type of vulvodynia. Do you differentiate? Did you differentiate the vulvodynia from generalized vulvodynia and localized vulvodynia? And I would like to know that if there is any difference of pains in between those two groups.
Right. I've not looked at the difference in the relationship between generalized versus localized vulvodynia and its relationship to lower urinary tract symptoms. I will do that. The large majority of women in this data set have localized provoked vulvodynia.
Hi, Lydia Johns-Butcher from Australia. With your vulvodynia ladies, do you think, I know you excluded IC and BPS, but do you think that there was a subset of them who really did fall into the IC-BPS?
Absolutely. There's no question. I have very good clinical confirmation of the vulvodynia itself. Whether or not they truly had either bladder pain syndrome or cystitis, I have no idea. So there's absolutely some misclassification from that perspective. But I would argue that not all of the association is due to this misdiagnosed comorbidity present. It would just be hard for me to believe.
So on that same vein, can you tell us more clearly how you excluded the presence of UTI? Is that excluded?
We adjusted for UTI, but we excluded women who self-reported having a clinical diagnosis of interstitial cystitis a diagnosis, okay, or having symptoms associated with bladder pain. It's very messy. So I absolutely know that.
That's the hard part. If
yes,
you're going to exclude the symptoms, I think that
there's
makes it difficult.
There's no question. But what we were trying to do is get as clean a data set as we could in women with vulvodynia and not IC-related types of symptoms, and this is a new area for me. So, in fact, I've not seen anything in the scientific literature looking at this relationship independent of IC.
Because clinically, I think patients that have what may be pure vulvodynia very often have dysuria and pain after urination, and they may have otherwise normal bladder function. So that makes it kind of hard to split this out.
Absolutely, but I think what that suggests is that there needs to be more integration between urological care and gynecological care for this condition, which I don't think is really happening.
Okay, we need to move on. Thank you so much for the presentation.